Hello, good morning everybody. It is Dr. Nick Andrew here coming to you live from sunny Gold Coast. And I'm here doing another Facebook Live session with Glaucoma Australia. This time I'm being remotely co-hosted with Sapna from Glaucoma Australia, who's going to be sending me in an ordered list of questions as we go. Last time was phenomenally successful, so we discussed COVID-19 and lots of great comments, lots of great questions that came through after that. So lots of shares, lots of views. So that's fantastic. Here we are back, and the people have spoken. The polls went out to discuss what we should be doing at this time, what we should be discussing, and we are going to be tackling glaucoma treatments. So this will be drops, laser, surgery, MIGS, traditional surgery. That's what we're covering. Obviously a really big topic, but I think we can actually do it in a way that's going to be useful and meaningful. We might come back to certain things another time to break them down in more detail, but certainly feel welcome to send in your questions and comments as we go, and I'll answer those as we progress through. So basically, I'm going to give you a framework for how to understand all the different treatment options that you have. I don't want to go through and spell out things that are already going to be obvious to you. So we don't need to discuss that eye drops maybe aren't very intimidating and maybe surgery is a little bit more intimidating. That's kind of can be accepted. Let's focus on what's really interesting or what maybe some considerations perhaps you haven't thought of before. But first, the most important part of any show like this is the disclaimer. So please understand, today's educational content. It's not specific medical advice. I really hope you find what I discuss useful and you can embrace and learn from it, and maybe it will alter your opinions or attitudes or the way that you are managed, but it's not specific medical advice. If something really resonates with you, or if what I say makes a lot of sense to you, then go and speak to your ophthalmologist or your optometrist about it. So let's set the scene, hey? So we're talking about eye drops, laser, here we go, messages coming through already. Eye drops, laser and surgery. So I need to explain something first of all. You're obviously, people are listening to this right now, you're listening to this because you want to know what treatment is best for you. And I'll certainly be able to answer that for you, but the question about, will help you to answer that, but the question about what treatment is best for you is an individual decision. It depends on your disease, it depends on your situations. So there's no one-size-fits-all treatment for glaucoma. There's no cookie-cutter approach for glaucoma. And I just want to explain this just a little bit. So the best treatment for you is going to depend on many things, but principally two things. The first is going to be your glaucoma severity. And so that I mean that someone comes to me, if one patient has very mild glaucoma and the other patient has severe glaucoma, that's completely different kettle of fish. They may as well have entirely different diseases. I know there's a common mechanism going on there, but for all intents and purposes, from a management point of view, those are entirely different scenarios. So a mild glaucoma patient, maybe pressure's slightly elevated, the visual fields are full, there's just a little bit of structural change on the OCT, versus an advanced glaucoma patient who only has small windows, small islands of visual field left. They're very, very, very different circumstances, and my treatment recommendations, what I discuss, would differ dramatically for those two individuals. So for someone with mild glaucoma, it's unlikely in the majority of those individuals that they're going to lose vision in their life that's going to dramatically impact on their quality of life. Let's put it that way. So knowing that, and there's obviously variation here, these are generalizations, but knowing that the risk of someone, let's say coming in their late 70s with a diagnosis of mild glaucoma, their risk of losing vision or losing their driver's license from glaucoma is really quite small. So knowing that, the greatest disservice that I could do to them is to prescribe a treatment that is going to ruin their life, that is going to be worse than the burden of their glaucoma. So we give them lots of different drops, and the drops have side effects and they're very frequent reviews, etc. That would be a disservice to that person, in my opinion, because as a doctor, I'm really here to improve people's quality of life. So in someone with mild glaucoma, my emphasis is always on finding a treatment that is going to be the least invasive into their quality of life. For advanced glaucoma, that person is at high risk of losing vision or losing their ability to drive from their glaucoma. And so that person needs really all the treatments they can get. And we would happily exchange some side effects or some risk for them keeping their vision. So there's a saying that eye care professionals in general, we over-treat mild glaucoma and we under-treat advanced glaucoma. And so if someone comes to me with mild glaucoma, often I'll be scaling back what they're on, whereas if they come to me with advanced glaucoma, I'll be escalating treatment. So severity certainly impacts on what sort of treatment I would be or you may be recommended. The other big factor that impacts this is the glaucoma subtype that you have. So the type of glaucoma treatment that may be best for a given person is going to depend on the subtype that they have. So the majority of glaucoma in Australia is primary open-angle glaucoma. So this means that the eye is essentially healthy. We look at the eye, we examine the eye, and it's otherwise a healthy eye. Just the pressure's a little bit high, and the optic nerve shows characteristic changes of glaucoma. Whereas a secondary glaucoma is one where the eye is intrinsically diseased. There's intrinsically something wrong with the eye, and a side effect or a byproduct or a downstream effect of that is elevated eye pressures and glaucoma. And so typically for the secondary glaucomas, the most common that we see in Australia are examples where protein or pigment might shed from the eye, and so little dust-like particles float around in the fluids of the eye, and they migrate towards the filters or the drain of the eye and deposit there, and that over time starts to block up those drainage channels and the pressure becomes higher. It's sort of similar, analogous to a pool filter or a skimmer basket in a pool filter. If you have leaves floating around in the pool water, they're going to tend to migrate towards the skimmer box, and you can have a few leaves in a skimmer box and the pool water can still be filtered fine, but over time, as the more and more leaves come and block up this skimmer box, obviously the fluid can't be drained effectively or filtered effectively. So those are kind of my caveats and disclaimers before we really get into it. Today is educational content. It's not intended to be specific medical advice, and the best glaucoma treatment for you is always going to depend on your individual circumstances and your individual situation. And so if something that you listen or understand really resonates with you, by all means go and speak to your optometrist or ophthalmologist after this session. All right, I see questions coming in already. But what I'm going to do, I'm just going to continue on and going to structure things to first talk about glaucoma drops, and then we'll move on to laser, and then we'll move on to surgery. Hopefully we have time for all of those. If not, we'll come back next week and we'll finish off. But let's start with glaucoma drops. It's obviously has been traditionally the mainstay of glaucoma surgery, certainly in Australia. And so let's start with a question. So we've had a question to Glaucoma Australia recently, which was, why can't we just use glaucoma eye drops for everybody? Why do we even really need laser or surgery? Or maybe I should phrase that, why can't we just use medications for everybody? So it's a good question. The thing is that in my experience, and certainly the evidence supports this, that drops in isolation or medication in isolation often aren't the best treatment at any stage of glaucoma. So let me just repeat that again. So drops in isolation or medications in isolation often aren't the very best treatment for any stage of glaucoma. Now, my approach to eye drops or medications is they're a fantastic adjunct. So they're not a workhorse for me, or I try not to use them as a workhorse for me. They are a little addition that can get me across the line. So I think of it sort of like the early hybrid cars. You know, the very early ones 10 years ago, how they were basically just a petrol car, but they had a little electric engine in them just to make them a hybrid, give a little bit of extra boost. So to me, that's sort of the role of the eye drops, is like the small electric engine. The workhorse, I try to emphasize to be something else because I feel I can achieve better outcomes for the patient, and the drops gets the patient up over the line or gives them that extra little boost. So I say this because in mild glaucoma, the burden of drops can potentially be worse than their glaucoma is going to manifest in their lifetime. So we give people lots of drops. The drops have side effects. The drops can cause redness or pigmentation. They can make the eyes uncomfortable. There's the cost of going and filling the prescription. You have to go and get repeats and go to the chemist each month, keep the drops in the fridge, travel with them, etc. Have a schedule that you arrange the drops. So there's a lot of daily activities that are associated with being on glaucoma eye drops that can detract from from a person's quality of life. So that's why in mild glaucoma, unless they're really required, I feel there can sometimes be better solutions. Sometimes. There's variation here, but this is my philosophy, and certainly I feel the evidence is more stacking in this favor. For advanced glaucoma, so the complete other end of the spectrum, drops, certainly in my experience, and again, the published evidence is emerging to support this now as well, but drops are rarely the best solution, and drops in isolation are rarely completely adequate. The issue is that most drops don't blunt the peak pressures particularly well. So when we have pressure, this will be a foreign concept perhaps, but eye pressure is not stable. Eye pressure varies up and down. It's like a yo-yo. It's like a sinusoidal curve. During the day, hour to hour, depending on what we're doing, etc., your pressure is going up or going down. It's not a smooth curve. And when we look at pressure, all the different pressure parameters, what is it about pressure that is actually causing damage to the optic nerve? Is it the average pressure? Is it the peak pressure, the minimum pressure, the area under the curve? Is it the fluctuation? And there's certainly strengthening evidence that the peak pressure and the pressure fluctuation is very, very important predictor or prognostic factor for glaucoma progression. So I look very carefully at that in terms of assessing the benefits or the strength of therapies. The problem is that a lot of the commonly used glaucoma eye drops are not particularly effective at blunting peak pressures or blunting pressure fluctuations. I could go into the pharmacology of why that is, but that's the issue with, that is one key issue with glaucoma medications. Let me give an example. I had a patient come to me last week who came to me for a third opinion of their glaucoma. They had very advanced glaucoma with just a small island of visual field left in one of their eyes. And this person's very detail oriented, had a very detailed summary of all the treatments they had received previously. They were on lots of drops, had SLT, a very detailed log of what the pressures were and how the pressures were changed by each small adjustment to their therapy. And in general, looking at the numbers on the page, you would get an impression that their pressure was reasonably well controlled. You could see that with each adjustment in treatment, there was a small 5% shift, 10% shift in terms of the pressures. Little millimeters of mercury gains here. And overall, the pressures were okay, not fantastic, sort of like 14, 15, but borderline, let's say. However, just from my experience and what I know, I was very suspicious that this numbers that we were seeing on the page weren't reflecting at all the true disease control. And so I did a little glaucoma challenge test in the clinic, and basically within the space of 45 minutes, with the patient doing a fairly normal activity, the pressure in both eyes went up to 28. And furthermore, the patient then rented a device where they could measure their own pressure over 24 hours, and over the next 4 days, it was very clear there was a daily pattern of the pressures peaking to around 28 to 30 in both eyes every single day. So this is a patient who's on lots and lots of glaucoma eye drops. During clinic hours, once they've got up, put their drops in the morning, etc., during clinic hours, they're seemingly under reasonable control. But there's still an awful lot of pressure fluctuation and pressure peaks going on, and eye drops are not particularly good at blunting those. There's stronger and stronger evidence coming out about this, and so in advanced glaucoma, when the natural outflow system of the eye is so compromised, using eye drops, they can't completely offset that. You still have an eye that can't really drain fluid well, and therefore it's not intrinsically good at blunting the natural pressure fluctuations that occur in all of us. And so those pressure fluctuations really get magnified in advanced glaucoma. So when you take, or just to maybe emphasize on that point, when you take medications, just to explain what they do, if you have that sinusoidal curve, you can lower the overall curve. You can lower the average and bring that curve back down more into the normal range. And that's why we see during office hours the pressures are better. But it still has that fluctuation. It's still not a stable pressure. And those fluctuations inside the eye over time can still be damaging to the optic nerve. I mentioned before about the burden of treatment. This is certainly relevant in mild glaucoma or earlier glaucoma. So what is potential burden of treatment? So burden of treatment encompasses many things, obviously side effects, filling scripts, complex regimens, remembering the drops, keeping them cool in the fridge, all these sorts of things. Side effects is obviously the big one. So let's just sort of focus on that. The predominant eye drops that are prescribed in Australia are going to be the beta blockers, so Timoptic, etc., or a prostaglandin analog. And we really like these. The prostaglandin analog with things like Xalatan or Lumigan or Travatan, or they can be in combinations like Duotrav or Zalacom or Ganfort. So we like these drops because they're quite effective at lowering the average pressure, and they're once a day, so they're really convenient. So that's why we use these drops. Well, they're the most frequently prescribed medications. But side effects includes, for a beta blocker, certainly in males, it can cause erectile dysfunction, and I think that is probably more common than what we inquire about and ask. So I think that's something that always factors into my mind with males. And prostaglandin analogs have some side effects that are cosmetic around the eye, which, again, in mild glaucoma, I just have to start weighing up whether we really want to go down that path or what the risk is. So cosmetic side effects. Basically, the issue here is that the prostaglandin analogs, the Xalatan, Lumigan, etc., the eyeball actually retracts into the skull. It causes shrinkage of the fat around the eyeball, and as the eyeball retracts into the skull, the eyeballs are drawn together. They retract towards the middle of the skull. So the patients can develop a sunken look over time. Some of you might be familiar or understand what I'm saying here. A sunken look of the eyeballs, some darkening around the eyeballs, etc. as well. There was a study that was published late last year. Excuse me. A study published late last year. And this study looked at patients who had used a prostaglandin analog, so Xalatan, Travatan, Lumigan, for an average of about 12 months. And it measured their distance between the pupils at the end of that period. And in general, the patients who had taken the most potent prostaglandin analog, the distance between the eyeballs was 2 millimeters closer after 12 months, which I find staggering. So after 12 months of using a glaucoma eye drop, the eyeballs themselves were now 2 millimeters closer together due to the way that these drops can affect the tissues around the eye. Now, I'm just going to mention here for a second. I'm not suggesting that anyone should be stopping their drops, etc., or reconsidering their treatment necessarily. The question is, though, we just need to be mindful of all these things, and I think it's better that everyone is aware of the potential for some of these side effects, because previously, up until recently, we didn't really have any great alternative options for glaucoma. That was certainly true in the past. Now that some other therapies are coming through, and I know we had lots of questions about these other therapies, it's better to actually sort of air and discuss some of these other things so that we can have a sort of informed discussion. Previously, we were certainly sort of stuck behind a rock and a hard place, I would say that, in terms of, yes, eye drops did have some side effects, etc., and they were a bit of a nuisance, but the alternative options had some big risks too. So now the scales are starting to even up a little bit, and so these things are open to discussion. I will just say as well that the side effects of drops are variable. And so what I was talking about here with the retraction of the eyeballs, etc., that is more seen with certain types of eye drops than others. The study was clear on that. And it's also variable patient to patient. I see some patients of mine who have really florid side effects from some of their drops, a lot of scarlet, purplish discoloration, a sunken look of the eyes. And then you'll see the next patient who really doesn't seem to react in that way. So I'm sure a lot of you are controlled on eye drops and you're doing really well and you're not noticing many side effects at all, and that's fantastic. You're a great person to continue. But in general, if we're having a discussion talking about glaucoma treatments, then I think this is something that's really important to bring up. So in summary, I still use the really potent eye drops. I use them in people who really need them. So in the more advanced glaucomas, or if I'm temporizing things, I certainly use them then. But I generally reserve those types of drops with more significant side effects as a last line treatment. That's my approach. The question is, could we use drops? Coming back to the question, could we use drops or medication for everybody? And potentially, maybe with Diamox, with tablets, we could temporize a lot more people, but the really answer is here, there are better treatment options. And so that's the way that I'm thinking. Now, the other big thing about eye drops, obviously, is compliance and adherence. So what is this? So compliance is basically, if I prescribe you an eye drop and I say use this one in both eyes in the morning and use this other bottle 3 times a day in the right eye only. So that's the instructions of how to use the drops. Compliance is what proportion of time you remember to do those, and you get a successful installation of an eye drop. It doesn't dribble on your cheek, etc. You actually manage to instill the eye drops as directed. We've known for a long time that compliance is a problem with eye drops, and it's not that people don't care or patients don't try. It's just that it's really difficult to do something regularly, and it's even the motor skills required to even instill a drop is quite challenging. There was a great study back in 2009 by Constance Okeke, who is a US glaucoma specialist I know, and basically this study, they fitted an electronic sensor to glaucoma eye drops. So they enrolled patients who were on glaucoma treatment, and they gave them this eye drops that had a glaucoma sensor on the delivery mechanism, so they could actually register each drop that went in. And of those patients, 50% of the patients used their eye drop less than 75% of the time. So it's interesting because these patients, I'll just say that again. So 50% used their eye drop less than 75% of the time. These patients knew they were being monitored. They knew what the purpose of the study was, and they were given free medication. So there was no disincentive for them to have to go to the chemist or work that into their life. They were given everything, and they knew they were being enrolled in this study to study their ability to comply with the treatment regimen. And the treatment regimen was once a day. That's it. The study was also only 3 months. 3 months long, so not long. We're not talking about a lifetime of therapy. We're talking about a 3-month study, free medications, patients enrolled, and they knew what the purpose was. And 50% of them were less than 75%. It's interesting as well, if you look at the results, there was a large increase in use of drops just before a follow-up appointment, and there was a large increase in use of drops just after a follow-up appointment. The issue here is that if people were using their drops before they return to see their optometrist or their ophthalmologist, then the pressure that's measured is going to not truly reflect what their pressure control has been in that last period. The other 2 things that came out, it's a very interesting study, is the patient's self-reported adherence, what percentage of time they instilled their drops, was much higher than what it actually was based on the dosing mechanism. And I guess it makes sense. Ivan Goldberg, who does a lot of work with Glaucoma Australia, has a great saying. He's like, how can we expect anyone to remember to tell us what they forgot to do? How can you remember to tell that you forgot your eye drop last night? It's very hard, unless you have a schedule or alarm or something else. The other thing was that the ophthalmologists were assessing, trying to gauge from the patient what they thought their compliance rate was. So they're asking them questions and trying to assess what they thought. And they were very poor at being able to determine which patients were adherent with the treatment and which ones were struggling to use the eye drops. So it does raise a lot of questions and issues. Obviously, glaucoma eye drops only work if you put them in, and so these are some of the considerations with them. So, summary. Let's sum up glaucoma eye drops. I do like glaucoma eye drops, but as an adjunct. I think they have a really important role. I couldn't manage patients to the same level if I didn't have glaucoma eye drops, obviously. I use something else, usually, as my workhorse to get the majority of the way. Depends, though. I usually like it if I can restrict the medications to 1 bottle, ideally 1 or 2 drops a day, and the best side effect profile for the patient, minimal side effects. I do use the potent eye drops, and I do use a lot of eye drops in those that really need it. But in general, that's my last line of treatment for those individuals. And usually when I get to that stage, I'm well and truly thinking down the lines of surgery. And I'll come to that. Just again, don't stop taking your eye drops. For many people, eye drops can be really well tolerated. They can be a great option. It's highly variable in terms of the side effect profile. But if some of the things I've said do resonate with you, or if just what I've said just really makes sense to you, then by all means, go and speak to your optometrist or ophthalmologist, seek an opinion, and I hope that's been of some help to you. So let's do some more questions. So these are some questions that we've had even before the session started, by the way, but feel free to type in more questions as we go. So how does a doctor determine what type of glaucoma eye drops are best for me? This is the question. How does a doctor determine what type of glaucoma eye drops are best for me? So this is basically going to come down to the potency and the side effect profile. So potency is obvious how effective the eye drops are. Side effect profile, maybe less obvious. Things I weigh up would be whether the drops are going in both eyes or one eye. If you have cosmetic side effects, it's much more obvious if the cosmetic side effects are unilateral, because you always have comparison when you look at someone's face. So unilateral eye drops is going to steer me down a different path to bilateral eye drops. If the patient's male or female, that has impact. The color of their iris has impact. The number of doses per day. So some medications are actually listed as being 3 times a day. In reality, majority of people only prescribe those twice a day because 3 times is actually really hard to manage. But that's a big impact. Going from once a day to twice a day is a big impact, and going to 3 times a day is another big impact on how someone's going to function and manage. There are other medical comorbidities, so where they have asthma or any other diseases, including diseases of the eye, and simple things like whether they have to keep the bottle cool or not, keep them in the fridge, if they're traveling lots. All these things can play into what is going to be a side effect profile of medication that's going to fit best with that patient's lifestyle. So in terms of determining the best eye drops, it's potency and its side effect profile. Okay, another question. And feel free to fire in some questions here. I've got my phone ready to answer as goes. Sapna's going to be texting in news. So another question we received. My friend has 1 eye drop and I have 3 different eye drop types. So why would that be? So this really comes down to what the pressure target is. So when you see an ophthalmologist or an optometrist, or mainly when you see an ophthalmologist, they will be determining what pressure is the target pressure. So what's the maximum pressure that we feel, here we are, questions coming in. What's the maximum pressure that we feel you could safely run at and remain stable? That's your target pressure. And we're going to try and use treatments to get below that target pressure. And the target pressure is always being revised. If you progress, we need to lower the target further, etc. So in terms of that, 1 person on 1 drop, 1 person on 3, it comes down to the target pressure. Probably the person on 3 drops need a lower target than the person on 1 drop, or they're just not responding to the drops particularly well. Like I said, I don't really like having patients on lots of eye drops. Another reason is that as you add more drops, the incremental benefit you get from adding the 3rd drop becomes very, very small. So I might get a 20% or 25% pressure reduction from adding the 1st drop, then maybe a smaller reduction from adding a 2nd. By the time I'm adding a 3rd or 4th, the actual net benefit is becoming small. So it's diminishing returns. However, as I add more drops, the side effects are not getting smaller. The side effects are going up, and probably not just additive, potentially in a more multiplicative fashion. Is that even a word? So the as we add more drops, we're adding more preservative to the eye, adding more side effects, adding more frequency, adding more scripts getting filled, etc. So that's why in this situation of diminishing returns, adding more eye drops isn't always the best option. In general, for me, when someone needs 3 or 4 eye drops, I'm usually considering glaucoma surgery. Okay, so another question here. I'll have a look. Sapna sent one in. Maybe we'll take this one. Okay, Lynn. Can you take Timoptol while pregnant? Okay, I prefer SLT again, but my ophthalmologist is keen on eye drops. They are working. So most eye drops are actually safe during pregnancy. You have to be a little bit mindful towards late in pregnancy. Early in pregnancy and late in pregnancy is an issue. Timoptol during the I will respond to this in writing because I really don't want to be mistaken here. But Timoptol certainly during the mid phase of pregnancy is reasonable. SLT is very reasonable as well. So SLT for me in someone who is pregnant is a very good option because there's really no systemic side effects, so no potential risk of exposure to the fetus. The other thing about eye drops is, for instance, with Timoptol, you can use a once a day Timoptol, Timoptic XE, and just close the eyes after instillation, have a tissue, press firmly on the punctum, try to reduce the amount of eye drop that goes through to the nose. So the eye drop that reaches the bloodstream is not reaching it through the eyeball. The eye drop that reaches the bloodstream is going down the nose. You're blinking it down the nose. It's getting absorbed through the nasal passages into the bloodstream. So in order to reduce the amount of absorption of an eye drop, you can simply just keep the eyes closed afterwards, get a tissue and just keep pressure on that inner corner there, the inner canthus. Do that for around 3 or 4 minutes. That'll help to reduce any potential exposure. And this might be relevant. SLT might be a good option, but you might be one of the people that don't respond particularly well. So you may well need something. From Nathan, okay, if I don't use my eye drops for more than 24 hours, I get blurred vision. Why is that? Okay, that's interesting. So it would depend a little bit on what your eye drops are. So there are really two options here. The first option is that the pressure is climbing, and the pressure is climbing to a level that's starting to actually impact your vision. Now that would have to be very high pressure. Vision is not impacted in the short term by pressure in the range of 20s or even 30s. Pressure usually has to climb very high before vision's affected. If you have very advanced glaucoma, then it can be that even moderate pressure fluctuations do impact the pressure a little bit. But usually the pressure has to go very high before glaucoma is actually the thing that's affecting your vision. So that's probably less likely. A second option as to why the vision would go blurry after withholding your eye drops 24 hours. Second option is that you actually have some dryness on the surface of the eye, have dry eye. And the eye drops themselves have a vehicle, like a solution to them, and that can actually potentially make your tear film a little bit happier so that the tears are nice and smooth and glossy, and as the light strikes the surface of the eye, the first thing that it strikes is the tear film. And so if you have dryness, you're going to have blurry or hazy or foggy vision. And the characteristic sign of that is usually the eyes are a little bit uncomfortable, and if you have a few good forced blinks, then the vision improves because you're blinking some fresh tears over the eye. So that could be another reason why actually using eye drops makes your vision a little bit sharper, because the vehicle that the medication is in the bottle actually allows the tear film to improve slightly. So I'll just adjust this slightly. The third option for that is that perhaps the pressure's going up a little bit higher when you don't use the 24-hour, when you don't use the drops for 24 hours, but your eye is very susceptible to that pressure fluctuation. So we all need eye pressure to keep the eye inflated to maintain the position of the optics inside the eye. So we have a cornea at the front window, then a lens, and then the retina at the back. Those all have to maintain a very precise orientation and curvature in order to give you focused vision. If you had a disorder of the cornea, let's say your cornea was very, very thin, so maybe you had previous laser vision correction, or maybe you had keratoconus, or some other ectasia of the cornea, which means the cornea becomes very thin and weak, then it can be that even fairly mild pressure fluctuations inside the eye cause the eye to expand or shrink more than what it normally would. And that can affect the curvature of the cornea and make your vision go, usually not blurry, usually more far-sighted or nearsighted, depending on what the pressure is. I've seen a few patients who have that. Usually they have keratoconus or have been over-treated with laser vision correction. But those are a couple of little hypotheses as to what could go on. We've got one more question here that we got asked before that we went to air. And that is, I have heard that some new eye drops that are being used overseas, but why can't I get them here? So there are some new eye drops, new glaucoma eye drops, that are available in certain parts of the world that are not yet available in Australia. So the drops this person is probably thinking of are called Ropressa and Vyzulta. So I actually have quite a lot of experience with these drops because I've spent the majority of last year working in Toronto, Canada. And certainly we had a lot of patients coming to see us in the unit there who were on these two medications. What I would say about these medications is, yes, they can lower the pressure. They're quite effective. They're arguably more effective than any single drop we have in Australia, or at least as effective as any single drop that we have in Australia. But they have their problems too. So I would look at these drops as saying they are not going to be a savior for many people, but they can be a temporizer in terms of, I do not expect that many people are going to find that this can resolve all their problems and they can stay on these drops and that will be it for them. Usually these drops are added towards the end of treatment therapy already, and like I came to it, it's diminishing returns. You can get some benefit, but the benefit usually is only modest once it's been added to multiple treatments, and they still have associated with pressure fluctuation, and they have side effects. Ropressa is the one that certainly I have more experience with. Ropressa has some strange side effects. The side effect is actually eye pain. Now, all eye drops, you could say, are associated with eye discomfort because they can cause dry eye, but eye pain is actually a description for Ropressa, and it's really like a dull ache around the eye. It's very specific. It causes quite a lot of redness as well on the eyeball, but the description is actually eye pain, and that's how people describe it, as an ache around the eye. So these things, yes, they are potent, but they do have their problems. Out of interest, that person who I just referred to, the patient I saw recently who was seemingly had good pressure during the day, but was actually peaking to about 30 every night, that person was on Ropressa, okay? So these medications, yes, they can lower the average, but you can still have significant pressure fluctuations. So in mild glaucoma, I probably wouldn't put someone on these drops because they cause eye pain. In advanced glaucoma, I probably wouldn't be really recommending these drops because they're still going to have pressure fluctuation in the majority of cases, and we're now adding multiple drops and having side effects, etc. I would certainly use them to temporize. So if someone had to travel overseas or just couldn't have treatment, like surgical treatment, etc., then by all means, we could use drops to temporize things. Or if they just really wanted drops, then of course, no problems. But it's unlikely that these drops, in my experience, are going to be a savior for a great deal of many people. I don't know when they're becoming available here. We can certainly look into that, and perhaps we can post Sapna after the session's over. Okay, how are we going? 35 minutes in, and all we've covered is eye drops. There's actually lots more we could discuss on eye drops too, but we'll move on. We'll let's discuss SLT laser. So, all right, SLT laser. So what is SLT? Many of you will probably know already, but for those that don't, SLT laser is on a device that looks like a slit lamp, like a microscope in clinic. You put your chin on the device, there's a little contact lens that rests on your eye, and this slit lamp has a laser mounted in it. The laser is a green laser, and it fires ultra short pulses of light energy, just 3 nanoseconds long, and these are directed into the trabecular meshwork, which is the drainage channel of the eye. So what these pulses do is it's not a cutting laser, and neither is it technically a thermal laser. It does heat up the tissues that it's directed towards, or the target cells, but it's so brief that there's no real thermal transmission. There's no heating of the surrounding tissues. So it's not a cutting laser and it's not a cooking laser. Basically what it's doing is it's providing pulses of light energy to stimulate those cells that normally live in the drainage channels, and it makes those cells more metabolically active. So it makes those cells more efficient at cleaning out the drainage channel and cleaning out the debris that's been blocking up the drain in glaucoma. Because just to emphasize that point, glaucoma is not a disease where you're producing excessive fluid inside the eye. Glaucoma is a disease where the fluid is not draining normally from the eye. And so SLT is good in that regard because it is targeting the mechanism of glaucoma, which is an outflow problem. It's a blocked drain. And so SLT is targeting the cells that normally clean out that drain. And so I think of it as sort of a rejuvenation for the eye. Now the true mechanism of SLT is a little more complicated than that, but that's certainly a way to think of it that encompasses most of the key concepts and is a reasonable understanding for what we all need to understand. So, why do I like SLT? So, I do like SLT. The reason is that overall, it's an effective treatment. If we look at the studies, around 85% of people who have SLT have a good pressure lowering response from SLT. It's durable, so the average duration of effect of an SLT treatment is around 2 to 3 years. Some don't last that long and some last much longer, however, but the average is around 2 to 3 years. It's repeatable, so SLT doesn't cause, when SLT is done correctly and not too much, but when SLT is applied, it doesn't cause any permanent scarring or any permanent structural change to the trabecular meshwork or drainage channel of the eye. And that's including on microscopy studies as well, under high resolution. And in general, SLT is really well tolerated. It only takes a few minutes. It's not painful. It doesn't hurt me a bit. I don't think it's particularly threatening. Certainly when you talk through patients as to what to understand, or explain it to them so that they're aware of what they're going to experience. I don't think many patients at all find it threatening or intimidating. And in general, it has very minimal side effects. So what are the side effects of SLT? So like I said, 85% of people do get a good response in general, which means around 15% really don't get a dramatic pressure response. So that could be a side effect, the potential or the risk of it not being effective for you. You can get a pressure rise after SLT, so it's usually a short-term pressure rise that occurs after about 45 minutes to an hour after having the treatment. So what I do to offset against that is I'd usually pre-treat with a special glaucoma eye drop just before I do the SLT, and I would keep the patients around in the clinic for around 45 minutes and check the pressure before they go. you'll be able to identify most instances of patients who have a pressure rise or pressure spike by doing that. In general, the pressure spike is short-lived. It's very uncommon that you require someone to go on a prolonged course of eye drops or tablets to control a more prolonged pressure spike. But that is a potential risk, and I'm certainly wary of that in certain patients. It can cause some redness. So after an SLT, successful SLT, patients often say their eyes slightly light sensitive for a few days, can be slightly red. And that's a good thing actually, because SLT works by triggering some inflammation inside the eye. Late last year, there's a paper published called the SALT trial, which looks at anti-inflammatory drops after SLT. And basically, the conclusions were that it's good to give a weak anti-inflammatory after SLT. We want a little bit of inflammation inside the eye, but not too much. Just enough to stimulate these cells to clean out the drainage channels, but not too much to overwhelm and potentially cause scarring or prolonged pressure rises. So I certainly give a weak anti-inflammatory afterwards. But those are the side effects. It's pretty minimal overall. You can get some rare things like prolonged inflammation or marked inflammation, even some swelling of the cornea, but these are really the rare and wonderful type things. Like I said, we can also offset these risks. So in terms of pressure rise, that's kind of the biggest thing I watch for. Pressure spikes are usually of no consequence to most people, but if someone had advanced glaucoma and I was doing SLT, I'm very wary of that. So I would pre-treat them with glaucoma drops. I check them after 45 minutes. I only do 180 degrees of SLT at a time. I don't treat the full 360 degrees in one session. And patients who are at particularly high risk of pressure spikes, and there are certain appearances of the drainage angle that put someone to a higher risk category, or certain subtypes of glaucoma that makes them at higher risk of pressure spikes, those patients, I will personally do a test dose. So I'll give a very small amount of SLT as a test dose, make sure they behave as expected. And if they misbehave, so if the eye gets a big pressure rise off a very small amount of SLT, then I probably wouldn't proceed. I would caution them very carefully against going for a full treatment with SLT. So look at the evidence. Let's look at the evidence for SLT. So there's been some very large studies in the last 18 months assessing SLT and comparing it to eye drops. So the largest of these is called the SLT Light study. It was a UK study. Here we go, questions coming in. I'll just continue on this and then I'll come to the question. But largest study was called the SLT Light study. So this was took patients who were newly diagnosed ocular hypertension or glaucoma. And so newly diagnosed, untreated, newly diagnosed patients walk into clinic. Each patient was set an individualized target pressure. So based on their severity, their age, etc., the study determined what pressure target they needed to require. Then the patients were randomized into two arms. One arm received SLT, so that's a 360-degree SLT with the option to have a repeat SLT, and the other arm could start on glaucoma eye drops and escalating glaucoma eye drops as required. And it was a huge study. So 652 patients were followed for 3 years. So that's a lot, that's a big study, and very difficult to manage a study of that size, very expensive too. So it's really good quality data. And the outcome from this study was that in the SLT arm, 75% of the patients were at their pressure target at 36 months after only one SLT and on requiring no medications. So just say that again. So in the SLT arm, 75% of the patients were at their pressure target 3 years later after only one SLT treatment, and those patients required no glaucoma medications. Just standalone SLT, the laser treatment had controlled them at their target pressure, which I think is pretty remarkable. And so that's certainly one of the reasons. There's a long track record of SLT data going back long before this. This only corroborates what I think was already apparent in the literature, but it's certainly encouraging to see. So SLT was as effective as medications. It actually cost the health system less. And those patients who had SLT actually ended up needing less trabeculectomy or less surgery. Now, hard to really read into that too much, but I think the study at least supports that SLT is comparable, and has some advantages over medications. Also in these studies, keep in mind that the medication groups always look a little bit better than what they do in real life. So if you come to see me as a patient and I enroll you in a clinical trial and I say this trial is going to be assessing your response, we're going to provide you with free medications, we are not going to let you get lost to follow-up because you're a trial patient. We really want to see you both to make sure you're okay, but also we need the data This the whole purpose of the study is to collect the data. So we're going to make sure that we do follow you up and you go, well, those patients in that scenario end up being more compliant with their medications and more compliant with their follow-ups than in the real world. That's just the reality. And so on these studies that compare medications and other things, usually the medication group looks a little bit better than what they usually do in the real world. Usually. That's just something just to consider. There was a smaller study called the Glaucoma Initial Treatment Study, GITS, the Glaucoma Initial Treatment Study. This was an Australian study. It was quite a bit smaller. It was 167 patients. This study, similar kind of design, however, it was a little bit more geared, it was a little more weighted towards the drops, my impression, or my understanding of the study. This study didn't find such a strong advantage of SLT over medications. In fact, the medication group did have slightly better pressure, but it was comparing SLT to the other drops in combination. And that's a pretty hard argument. So I would never try and say that SLT is better than all the drops in combination, no way. But SLT is comparable to maybe one of the drops or maybe even two of the drops in some individuals. So again, I use it more as a workhorse, and I'll then top up with some weak, well-tolerated drops, once a day as required. Also, if you look at the GIT study, the Australian study, and you just take people who only needed SLT versus the people who only had the eye drops, and you look at the side effects, the SLT group certainly had less eye redness, less eyelid redness, conjunctival redness, less dry eye, etc. So you can see the benefits of not having to put an eye drop in every single day and the side effects and toxicity that can cause. All right, Sapna, we've got some questions. Let's have a look. All right. From Rita, do you recommend laser on a boy age 13 and wears glasses? Do you recommend laser on a boy age 13 and wears glasses? Interesting. So it's a little difficult for me to comment on. I would want to know what subtype of glaucoma the boy has at age 13. So at such a young age, you're wondering about a secondary glaucoma. Is that something else happened to this eye, like previous surgery, etc.? Is there uveitis inflammation that has led to downstream effects of glaucoma? Or was the eye just born in a way that's really predisposed to SLT laser? And by that I mean that the collector system, the drainage canal, never developed appropriately for the eye. And the reason this is important is because that would prognosticate what the likely benefit of SLT laser is. So if the canal and the drainage system have never developed appropriately, they have dysgenesis, which means they've never developed normally, then it can be really hard to rejuvenate a system that from the outset is compromised. I'm not to say it wouldn't work, but it would just weigh in my mind about the prognostic benefit of using SLT in that form. But I think overall, 13-year-old boy, he would be able to tolerate sitting in a slit lamp and having SLT laser. That would be reasonable. I'd have to know more about the case to really give a specific answer, and probably neither should I. I'm not the doctor, your son's ophthalmologist. I think if compared to the alternative options, if eye drops at a 13-year-old boy are going to be challenging and surgery, we don't want to be doing surgery unless we have to, certainly not at that age, then I think SLT, if you control the risks, you do it appropriately, and you follow the patient up, then it's a safe treatment, and he may well have an excellent response, and that might spare him from some eye drops or control the glaucoma for these years when it's going to be really difficult for him to control his glaucoma just being a teenager, etc. So by all means, I think it's a very reasonable consideration. I think it's a good question. I think it's good that you're considering it. Michelle, I have been told that laser treatment is not as effective with lighter colored green-blue eyes. Okay, all right. Is this correct? So that's a really, really good question. So there are, I'll explain what the rationale for this question is. It comes down to not the iris color, but it comes down to the pigmentation of the trabecular meshwork. So we're talking now about prognostic factors of what impacts how successful SLT laser is. Now, the pigmentation of the trabecular meshwork is what we're targeting with the laser. So the laser is targeting the pigmented cells. If you have a lot of pigmentation in the drainage canal, then it uptakes the laser better and you tend to have a more pronounced pressure response. And this is why in lots of secondary glaucomas where there's pigment that's floating around and depositing, you tend to get a really great pressure response from SLT laser. So it's the pigmentation of the trabecular meshwork, the drainage channel, that is a key prognostic indicator for how successful SLT is usually going to be. Now, is that related to your iris color? This is a really common thing that gets thrown around. I don't want to speak out of place here, but no, iris color and trabecular meshwork are not associated. That is something that you do hear discussed or mentioned. I've seen many patients, and this is not my anecdotal experience. This is what's known in the evidence, etc. as well. Many patients with dark irises, dark brown irises, and almost no trabecular meshwork pigment, completely pale trabecular meshwork. Versus I have patients with very light blue irises who can have abundant trabecular meshwork pigment. So it's the iris color does not directly determine the trabecular meshwork pigmentation. That is a very common thing that is still heard and said, and I certainly believe that myself for a while as well. But if you look at what's actually published in evidence, etc., then no. So I've never seen it published that iris color is associated with SLT response. No. Certainly trabecular meshwork pigmentation is, but is the trabecular meshwork pigmentation associated with iris color? No. Certainly not in my understanding, and not anything I've ever seen or read up on. But it's a really good question. Really good question, actually. It's a good question because there's a lot to that, actually. And it's controversial. All right, from Jesse, we are getting up to 51 minutes here. So we're going to have to wrap this up in another few minutes, I think. And I'll come back to do another one of these maybe next week, and we'll expand on it then. Jesse, are there any disadvantages of SLT as a first-line treatment for younger glaucoma patients in their 30s? Okay, great question. Really good question. Are there disadvantages from having SLT in a young patient in their 30s? The question is, the issue is here is you're going to have glaucoma for a long period of time, okay? Let's hope, Jesse, you're going to live till 100, okay? We've got 70 years or 65 years or of life and pressure control to achieve for you. So is SLT, you're going to need prolonged amount of treatment, and you're probably going to need, if we go down SLT, repeat SLT. So let's talk about repeat SLT for a moment. So this is a really topical or hot topic at the moment. I'm actually in the process now of just publishing a paper. I was just editing it last night, working with a fellowship supervisor, Professor Tony Wells, who I worked with in New Zealand. We have a large series of eyes that have had SLT 3 to 4 times. And these patients were managed purely with SLT. So they came to us with glaucoma. They've had SLT, had good pressure reduction, then pressure started creeping up after a couple of years, had repeat SLT, another good reduction, and then over time just managed purely with SLT and repeat SLT 3 to 4 times. And what's really interesting is that you would expect that with the first SLT, you'd get a really good pressure reduction. Maybe the second one, not as good. Third one, wearing off, and it's not starting to work as well. The results don't actually show that. The results show on repeat SLT that the subsequent repeat SLTs tend to be associated with greater pressure lowering than the primary SLT, and the duration of effect tends to be longer. Now, this is actually supported by the SLT Light study, which is that large paper I talked about very recently. Now, the SLT Light study showed the same thing. They only have data going out to 2 SLTs. They don't have 4 SLTs like we have, but they have slightly more patients. And basically, in their study, sorry, as my child is in the background here, but in their study, they were showing that that also repeat SLT is very effective. Now, do I think we can just be cavalier? Do I think you can just have repeat SLT, repeat SLT, repeat SLT? No, I don't. And now, I've seen many patients, or some patients, who after their 4th SLT or 5th SLT have prolonged sustained pressure rises. So I am cautious, and I don't want my paper to be interpreted to believe that you can just be cavalier and go firing SLT from the hip at anyone you see, because repeat SLT, yes, it's a viable treatment option that is successful in the majority of patients, but I've also seen problems from it. The issue with anything is how reversible is my treatment. So if I give you a glaucoma eye drop, I can take it back. If I give you photons in a laser, I can't take them back. So we always just need to be a little bit mindful of this. And so coming back to your question, SLT in your 30s, great option. Okay, you might have a great pressure response. You might be someone who lasts for 6 years or 8 years or 10 years. Those cases exist with prolonged pressure control. Or you might find that you need SLT repeated again in 12 months or 24 months, and you might need a number of them. I don't think you're going to be able to go, if that's the case, your whole life just being managed with SLT. I think SLT could be a bit of a workhorse to do some of for you and maybe find a glaucoma drop that suits with your lifestyle and doesn't cause you too many side effects. And then as you develop cataracts, maybe in your 50s or 60s, then I'd be looking more towards doing cataract surgery and MIGS. That'd be an overview of what I would be thinking, but it all depends very much on what your glaucoma severity is like. If you had really advanced glaucoma at age 30, then I'm very concerned we have to be right onto your pressure targets, because advanced glaucoma at a young age really increases the risk, the potential risk that if you're not well controlled, you could end up with a visually disabling problem later in life. And so if that was the case, then I probably wouldn't be mucking around with SLT too much. I'd be more quickly escalating to more intensive treatments. So it depends. But overall, you answer your question, I think that is a consideration, SLT at a young age, is that how many times you're going to be able to repeat it. But still, I don't think it's a reason to necessarily defer SLT completely. I think it certainly could have a place. And there are some benefits from putting off the time before you need glaucoma eye drops, because the glaucoma eye drops, they do cause some inflammation of the surface of the eye. They do cause some very subtle scarring underneath the conjunctiva. And if you are someone who may be needing glaucoma surgery later in life, then you don't really want to have a huge exposure to glaucoma eye drops beforehand, if you can, because having a huge lengthy exposure to a lot of glaucoma eye drops before you have surgery is a well-recognized poor prognostic factor for outcome from your surgery. It can be handled. There are things that we can do, but I'm always of the opinion that if we can try and spare the burden of glaucoma drops, then that's really a service to the patient and service to their glaucoma. Let's have a look. Any other questions we had? Okay, I had one question here. This will be the last question I think I'll cover. And then how about we come back in a week's time and I'll discuss glaucoma surgery then. But last question, let's wrap it up here. So why do some people get SLT done first and other people go on eye drops first? And I just want to emphasize there's no like right or wrong answer here. I've weighed up some of the considerations about eye drops that maybe people hadn't thought about so much before, and some of the considerations, the new evidence about SLT. There's no right or wrong answer. I know some ophthalmologists truly believe that the majority of their patients don't want laser. They truly believe that the majority of their patients find laser intimidating and scary and they'd rather go on eye drops. Personally, I haven't found that to be the case. I think if you describe the laser in a way that is representative of the actual process and you acknowledge the risks, you certainly never downplay the risks, but the risks are small and you discuss what can be done to offset them, then certainly I've found that the majority of patients actually prefer to have laser and they're happier for it. I think maybe, should we call it there, Sapna? I think we're up to 57 minutes. I think that's pretty good. So, all right, guys, we were going to go on to glaucoma surgery, and that was going to encompass MIGS and subconjunctival glaucoma surgery, but I think at 57 minutes we've covered a lot. So let's leave it there. How about I come back in a week or 2 weeks, and we'll discuss MIGS and glaucoma surgery, and then maybe we can blend all of this together with a bit of a discussion about more comparing the pros and cons of each. So anyway, I've enjoyed talking with you. It's a big topic, but it's been good. Feel free to ask any more questions in the discussion thread, and I'll look at these in the coming days and type answers to you. Apologies about anyone who we haven't answered a question of during the show. We've just tried to prioritize things with having them screened through to me. And I'll certainly answer any questions that have been posted after the show. So, have a great time, everybody. Enjoy the last of quarantine, and I'll catch up with you shortly.